my pleasure now to introduce our last speaker this afternoon, Dr. Cesar Victora. He's an emeritus professor at the Federal University of Pilatus in Brazil, and he holds honorary appointments at the Universities of Harvard, Oxford, Johns Hopkins, and the London School of Hygiene and Tropical Medicine. He is the recipient of this year's John Dirks Canada Gairdner Global Health Award. It's an award named in honor of our former president of the Gairdner Foundation, Dr. John Dirks, himself a pioneer in kidney research, and it honors Dr. Victora today for his outstanding achievements in global health research. In particular, he's being recognized for his contributions to maternal and child health and nutrition in low and middle income countries, with particular focus on the impact of breastfeeding during the first few months of life, how this affects mortality and the long-term impact later in life on health and nutrition. He obtained his MD at the Federal University of Rio Grande do Sul in Brazil, his PhD in healthcare epidemiology at the London School of Hygiene and Tropical Medicine, and he's been at the University of Pilatus since 1977. He was the founder and coordinator of their epidemiology research group. And from 1996 to 2008, he was the head of the World Health Organization Collaborating Center for Nutrition in the area of maternal and child health. He's been recognized with numerous awards. I'll just mention a few. He was elected to the Brazilian Academy of Science in 2006. And I think rather unusually, he was the recipient of both the Brazilian National Order of Scientific Merit in 2008, and then 2 years later, the National Order of the Medical Merit Award in 2010. And just very briefly, because he'll tell you more, he's interested in areas of child health nutrition, health monitoring, and the impact of following these children from very early life and looking at the benefits of breastfeeding in promoting health, not just early in life, but later in life. These studies that he'll tell you about today have helped establish the influence on the first 1,000 days of a child's life in maintaining positive lifelong outcomes. And they've contributed to global policy recommendations, both by UNICEF and by WHO, for mothers to breastfeed their babies exclusively for the first 6 months of life. The title of his presentation today is Think Locally, Act Globally, How Research Carried Out in Brazil Contributed to Global Policies. Please join me in welcoming and congratulating Dr. Cesar Victora.
Thank you very much. That's a great introduction. I'm really pleased to be here. I almost didn't make it because of a medical-related incident with my leg, but I'm so happy to be as part of a symposium here that shows how important science is. Ranging from molecules to pain pathways, vaccines, statins, Rett syndrome, organizing national stroke prevention programs, preventing dementia, and now, as the last one, I'm talking about the world. I'm talking about global health. So I went to, okay, here we go. I want to talk about how we can work in a relatively isolated place. I'm 4 hours away by bus from the nearest domestic airport in southern Brazil, where I catch a flight to São Paulo, and then I can travel to other places in the world, and yet be able to have some influence on global policy. And I started my presentation thinking about the environmental slogan, about the thinking globally, about climate change, pollution of the air and of the oceans, and acting locally to help, by working in your own community, achieve these global goals. I'm having some trouble with this here. Yeah, the keyboard's okay. Here we go. Pelotas is a city in the extreme south of Brazil. It's almost at the border with Uruguay and had a very rich past, so we have all these wonderful new classical buildings that were built in the 1800s when the city was still very wealthy, mainly to cattle raising and production of salted beef. But Pelotas is also, like other Brazilian cities. Okay, here we go. It's a mixture of rich and poor. Brazil has been one of the most inequitable countries in the world in terms of the distribution of wealth. It is slightly better now, but it remains with the massive differences between rich and poor, between blacks and whites, between men and women. So what struck me and what led me into my career as an epidemiologist was the fact that when I left medical school in 1976 and started working as a family physician in the slums of Porto Alegre and then Pelotas, it struck me that the same children got back to me repeatedly with similar disease episodes. So they would have diarrhea, I would treat them, they would go home, or they would develop pneumonia or measles. And I was really impressed with the fact that many of them ended up like the child in the middle here with marasmus and would eventually die. And that's when I thought, I want to do something about preventing these diseases. And I want to do something about some interventions that may be affordable, feasible, effective. And that's what drew my attention to breastfeeding. Breastfeeding was very uncommon in Brazil, very short in the 70s. It was believed to be something backward that was not in accordance with modern life. The modern way to feed babies was to give them formula. And we only had an average duration of breastfeeding of 2.5 months at that stage in where I lived and in Brazil as a whole. And that's when I did my first pieces of research on this topic, which evolved into other studies along the line. So I'm going to talk to you about 4 topics here. I'm going to talk to you about exclusive breastfeeding, the research I did in the 80s, and the WHO child growth standards, the first 1,000 days, and the importance of early nutrition on adult health and human capital. And I'm going to end up with the work I have been doing in terms of monitoring global trends in the health of children. So starting with breastfeeding. This was the first international paper I got, and I was so proud when I got the letter of acceptance from the Lancet in 1987, because up to that stage, all the evidence on benefits of breastfeeding against mortality and morbidity, they were based on studies carried out in the UK, in England, in Canada, in Scandinavia, in the early 1900s, when these countries still had very high infant mortality rates, and when there was a tendency, if you're not breastfed, you would get condensed milk in cans that would be diluted and given to young children. All the studies were old. They didn't have modern epidemiological or statistical designs that would allow to control for confounding variables and selection bias and so on. And what I did in the 80s was to take a study that was being disseminated very fast for cardiovascular diseases and for cancer, which was a case control study, which we all know has its limitation as a type of design that has its limitation, but still incredibly worthwhile for specific conditions. And basically, I reviewed 2,000 deaths of children that took place in the 2 largest cities in my state for a whole year. I identified the causes of those deaths through asking the mothers and reviewing case notes and so on. This is not my fault. Okay. And I took 2 neighborhood control children who were alive. So I took children who died, and I took 2 neighborhood control children of the same age who were obviously still alive, and I looked back at their feeding histories. And what I got was this. If you're, as a case control study, we look at relative risks. Breast milk was the low-risk category, a relative risk or an odds ratio of 1. 3.6 higher mortality if you had breast and formula, but if you only had formula or cow's milk, the relative risk was 14. You know, I've never seen a relative risk of 14 in my life before, so when I saw that, I thought maybe I made a mistake. So I went back and redid the calculations and so on and so on. But this part of the study basically confirmed for diarrhea the importance of breastfeeding. We had a relative risk of about 4 for pneumonia, and we had a relative risk about 2, ranging between 2 and 3 for other infections. So it was pretty strong evidence. But what was new there was that these kids, even if they were breastfed, they were getting this. This is a small baby bottle with a capacity of 50 ml in which mothers gave water or teas to the children because everybody believed that breast milk was not enough to supply the liquid, the needs for fluids of young children. So everybody was getting these. My kids were sitting here, were born in the 70s and 80s. They got these bottles. And so I was in a situation, I said, maybe these bottles are not so innocuous as they seem. But I was in a situation in which I was trying to study smoking and lung cancer in a population where everybody smoked. So I had to see, how can I do that? And that's when I decided to do dose response analysis and see if the number of baby bottles with teas or milk or water you got a day affected your risk of dying. And this is what I got. There was a clear dose-response relationship. 1 bottle a day, 2 bottles a day, 3 bottles a day, and these are the increases in the risk of death. So that study was the first one that ever showed that adding anything to breast milk could increase your risk of death. And it was rapidly replicated within a year or 2 by a study in the Philippines and a study in Peru by the Hopkins and North Carolina groups, respectively, and also by research showing that breast milk was a sufficient source of all the fluid that the baby needed. And anything you gave in addition to breast milk to children who have a tiny stomach would displace the amount of milk or breast milk that child could receive. Within a couple of years, and that was pretty fast, WHO and UNICEF issued a recommendation that exclusive breastfeeding should be carried out. WHO said for 4 months, UNICEF said for 6 months. Eventually they got together and they agreed on 6 months. And this is a global policy now. A lot of countries, Canadian pediatricians recommend that, US pediatricians. It's become an example of how new knowledge from epidemiological studies could be rapidly incorporated into policy. Let me move on now to the growth standards and how do we assess how young children grow. At that time, due to my previous work on breastfeeding, I was part of this WHO committee which was looking at anthropometry and one of the things we had to decide is which kind of growth charts should we use around the world to measure, to assess child weight and child length and other anthropometric parameters. And at that stage, WHO recommended the NCHS, the US-based National Child Health Study growth charts. But in fact, these charts were all developed from a single community in Ohio, from a longitudinal study. All children were white children, and 80% of them were formula fed. And what really struck us when we started thinking about the charts was that if you take a growth chart like this one here, and you flatten the growth chart, so there's no increase in weight, but you're looking basically at z-scores, and you put perfectly healthy, well-developed babies who are breastfed in this chart, it looks like they're above the chart for weight, for length, and for weight for length, up to about 4 to 6 months of age, and then they falter. They fall down the chart. So when you see a baby that is starting to falter around 3 or 4 months of age, and I say falter, quote unquote, the first thing that a pediatrician or a nurse or a nutritionist would do would to be, let's supplement this child. This breast milk is not enough to support the healthy growth of this child, so let's give the child formula, or let's give the child other foods. And we challenge this idea by saying maybe the charts are wrong. Maybe the charts are being based on formula-fed babies who are too fat. And in fact, we need a new type of chart. And that's when we developed the WHO multi-center growth reference study. We took healthy babies from healthy families, from healthy mothers, from high socioeconomic status families throughout the world. Obviously, we cannot develop a growth chart based on children who are undernourished and who don't have adequate water or sanitation or health care. So we went around the world. We found 6 places that were willing to participate in this study, and we selected families and mothers who would have who would allow the child to reach their potential growth trajectories. So they would be able to have optimal growth. This means, like in Pelotas where I live, we screened about 2,000 families and we got 300 into the study because those are the ones who are healthy. These are prescriptive standards, therefore. They are based on what we believe is optimal human growth. Well, first thing, to our surprise, these kids were breastfed too. That was very important. They had to comply with the feeding recommendations we had. The first thing that really struck us was we all think that Brazilians, for example, are short and Norwegians are tall. And looking at me and perhaps some Norwegian colleague in the audience, if there's one, you might be convinced that this is true. But in fact, the height of these children and the weights were remarkably similar. If anything, Brazilians were about 1 centimeter to 2 centimeters taller than the Norwegians at 2 years of age, because they had the right environment and the right nutrition. And therefore, when we looked at the statistical issues about pooling the 6 different sites, the remarkable similarity of the growth patterns of children who were breastfed in all these sites allowed us to do the pooling. In Pelotas, we started the study there. People from the other sites came. They were trained. They were standardized. And we produced the curves. This is the first child who finished the 2 years, the landmark in our city. The WHO growth standards were created among this. They were launched in 2006, and now they're adopted by 140 countries. So if you go to a clinic next door here in the university and you have a one-year-old baby, that baby will be assessed using our curves. So I think this is one of the greatest pleasures that a scientist can have, is seeing work being adopted in such a large fraction of the population. I don't know how many kids are measured every day against our curves, but it must be millions. Now, let me move on to the third part of my talk, and which is about the importance of early nutrition. And I'm going to talk to you about the Pilatus Cohorts. Pelotas, as I said, is a city with about 300,000 inhabitants in the extreme south of Brazil. And in 1982, my colleague Fernando Barros and I started a birth cohort study by taking all births in the city. There were 6,000 births in the city. So we took everybody who was born that year, started following them up. And then every 11 years, we started a new cohort. This means that Pelotas is one of the most studied cities in the world, I think, because we keep visiting them. And we have a number of, I was just looking at Janet here. I usually tell a story, which I say, whenever I go to a restaurant or anywhere in Pelotas, there will be somebody from a cohort. I say, oh, I'm in your cohort. They'll know me and so on. And I gave this same talk in Ottawa 2 days ago, and someone from the audience came up and said, hey, I'm in your cohort. She was a postdoc at the University of Ottawa. And just so happened that she was there on that day for this. We have a very high follow-up rate. The figures in the right, we're still following up at 30 years, 68% of those born in 1982. And we have moved quite a lot over time. We started, and our first grant was from IDRC in Canada. It was like about $50,000 to do the baseline study, the perinatal study of the first cohort. That's me on top there. Fernando Barros was my co-worker. We all had paper questionnaires. We rented an office downtown because the university didn't have enough space to allow us to work there. And from there, we moved on. We had home visits. We visited families of all socioeconomic groups, reflecting the diversity of the Brazilian population. And over time, our priorities shifted because when the cohort started, I was really worried about malnutrition and diarrhea and pneumonia and measles and marasmus. And over time, Brazil changed very fast. And now we have over 50% overweight subjects in our 1982 cohort. And we now moved on to much more complex assessments. We do body composition, we do abdominal ultrasound, we have GWAS in the cohort. So we really moved along, and the nature of of our study subject changed as with the epidemiologic and the nutrition transitions in the country. I just want to spend a couple of minutes here to summarize the results from a lot of work we have done on the influence of early growth on long-term outcomes. And this is another flattened growth curve in which 0 is the median. And we did this first analysis in pediatrics in 2001, and then we replicated it in 2010 with the new WHO curves with very similar results. But basically what we show is that children, and this is an average of 54 demographic and health surveys from low and middle income countries, and they are born a bit below the 0 line, the median birth weight. They're born probably around 3,000 grams, but then they falter in relative terms, in terms of Z-scores, very rapidly until about 2 years of age, and then they grow parallel to the standard. So this was new stuff. People didn't realize that there was such an acute period in which nutritional status was defined. And that gave the origin to the idea of 1,000 days. 1,000 days, the first 1,000 days included 270 days of pregnancy plus 2 times 65. The sum is exactly 1,000. And it's a great slogan for promoting the need for interventions in nutrition at this critical window of time. Now, we then started studying the long-term consequences because we now have long-term cohorts. And when I was invited to do a series on maternal and child undernutrition in the Lancet, I contacted colleagues from from the largest birth cohort studies outside Europe and in North America. These are, just by luck, we had 5 large cohort studies, one in Guatemala, one in Pelotas, one in South Africa, one in Delhi, and one in the Philippines, in Cebu. So we pulled our results together and started looking at issues related to the timing of weight gain and the long-term consequences that it had on health and human capital. We published lots of papers on diabetes, on hypertension, on adult height, and so on. And to make a very long story short, and given the time I have allowed here, I drew a cartoon, and my colleagues from the cohorts collaboration, which is how we call ourselves, they say this is an oversimplification, but I really think that in public health and in global health, we need rigorous oversimplification. Or maybe not oversimplification, but rigorous simplification to get our message across. So in this graph here, what you show here is the timing of weight gain, and using a very complex statistical approach called conditional weights in which we adjust for the fact that weights are not independent from the weight of the same child at another time period. And we showed that the child survival and human capital, they are promoted by rapid weight gain in utero and up to 2 years of age. So if you put on weight rapidly in a low and middle income countries, up to 2 years of age, you are less likely to die, and you become a more intelligent and productive adult based on the data from our long-term birth cohorts. The other side of the coin is this one, which is if you're worried about diabetes and hypertension and metabolic syndrome, you really, the danger here is when you put on weight after 2 years of age. In fact, weight gain early in utero and early in life, it actually even protects a little bit. And that's a Barker hypothesis that many of us have heard about, low birth weight being associated with cardiovascular mortality. So you want these kids to grow well in utero and in the first couple of years of life. And when you put the two together, this is what you get. You get that this very oversimplified graph, perhaps, but showing that there is a need to, here we go, promote optimal growth and prevent growth faltering up to age 2. But after that, you really have to worry about kids who are putting on weight too rapidly. And this is a real challenge for public health. It's not a simple message. You're saying, depending on the age, you need different approaches and you need different strategies. This is being widely recognized now. It's being incorporated by a number of programs in WHO, UNICEF, the World Bank, and so on. Now, this is the cohorts group that from the 5 continents that helped us do these analyses. So the other thing that the cohorts also allow us to do is to look at early nutrition and long-term impact. And I'm going to cut this really short, but we were able to look at breastfeeding and human capital by looking at the 30-year follow-up of our cohort and relating that to all the information breastfeeding we collected in the 80s. And this is what we found. We found that the duration of breastfeeding in southern Brazil was very short, and there was no social patterning. So we're not affected by the kind of bias that you get from breastfeeding studies, for example, in the US or Canada or Europe, where the rich, more educated mothers are more likely to breastfeed. So it was very, very even patterns of breastfeeding in all groups. And what we found, and all of these charts have the duration of breastfeeding here from less than a month to over 12 months. They go up. Intelligence go about 4 IQ points, adjusted for a number of factors. Schooling goes up by about a year, and we have very short schooling in this cohort, so a year makes a lot of difference on average. And income goes up. And that was the most striking aspect of our research, I believe, because it got a lot of publicity. We got headlines, and I was sitting at home and looking at CNN, and there was a running headline about my study. So it made a lot of publicity. Not all positive. I mean, there are quite a few concerns, and concerned mothers say, I can't breastfeed my child. I have to go back to work. This kind of research is unfair. That this should not have been published. But it is an example of how investment in long-term cohort studies can bring results that otherwise would not be noted. But going back to the issue of the guilt of mothers who don't breastfeed, last year we were again invited by The Lancet to produce a series of papers on breastfeeding. And here's our cover. Our cover said, success in breastfeeding is not the sole responsibility of a woman. The promotion of breastfeeding is a collective societal responsibility. I mean, you need to have the conditions in society, maternity leave, workplace protection, and so on, so that you can actually breastfeed successfully. This is what happened to Brazil, and again, I don't have a lot of time here, but when we started studying breastfeeding in the 70s, median duration for the whole country was 2.5 months. It's now 14 months. So most Brazilian mothers now breastfeed for over a month. And it was a result of a number of changes, starting in policy, control of advertising of the baby food industry, support to breastfeeding mothers, and so on. So that's a real success story on breastfeeding. Now, to finalize, as I moved along over time, I became more interested in the millions of children who were dying in developing countries. And in 2003, we had a group of people who met in this beautiful place of Bellagio. I'm sure many of you have been there. And we said we need to do something about the 10.8 million deaths of children that take place every year in the world. And we proposed a mechanism for monitoring the progress of countries. It's called the Countdown to 2015. 2015 because it was the end year of the Millennium Development Goals. We have been working together since then. It's a multi-stakeholder initiative. We have 42 logos in our group. I'm happy to be one of the coordinators of this effort. And we try to simplify things again. I think, we're really worried about translation. Each country gets a 2-page sheet with everything that is happening in terms of the health of mothers and children. We collect data from many sources. We analyze lots of surveys. And we can actually make that easy to interpret by policymakers. We do a lot of testing of our messages against policymakers from low and middle income countries to make sure that they understand what's happening. I'm particularly interested in inequalities in health. As I mentioned before, Brazil is a highly unequal country, and after many different attempts, we came up with this graph that we found that policymakers could understand. We call this an equiplot. And here's Nigeria, and here is Malawi. The line down here is coverage, ranging up to 100%, which is a percent of children and mothers who need an intervention who get it. And here are the interventions: family planning, antenatal care, and so on. And I'm sure Rino will be interested in looking at the vaccine coverage here in Nigeria, DPT3 coverage, showing that in the poorest 20% of the population, coverage is only about 10%, whereas in the richest 20% in Nigeria, it is 80% coverage. And I'm comparing Nigeria here, which is a very unequal country, with Malawi, which is a much more equitable country, where the difference between the poor and rich is smaller. So this kind of information is fed back regularly. We have meetings all over different countries. We bring back the epidemiological and the scientific data so that policymakers can invest. It's really important to work with the inequalities, I believe, not only for human rights and for moral reasons, but also because you can have better programs if you understand the types of inequalities that occur in each country, and you can target those groups which are most at need of health interventions. Just to make another example here before I conclude, this is stunting rates in Brazil. And this is a slightly different equiplot in which, of course, the poorest have 5 circles. Each circle is 20% of the population ranked by wealth. The poorest had about 60% stunting rates, that is low length for age or height for age. And the richest had about 12% in the 70s. And right now, we have had great progress in Brazil in reducing, not only reducing stunting overall, our national rate now is about 5%, but also in reducing the gap between rich and poor. We now have a new set of goals from the UN, the Sustainable Development Goals, which are with the deadline of 2030. We are working hard to monitor this. There are 17 goals, 17 areas with 169 goals. So we continue with our initiative. And one of the last of these goals is the need to have statistics disaggregated by income, by gender, race, ethnicity, and so on. And we're facing this job. This is the group that I work with, mostly young kids, mostly in their mid-20s, who are constantly analyzing data from multiple surveys. We have about over 350 surveys in our database to produce the statistics for these countries. We also produce all the data on inequalities in health that is featured in the WHO Global Health Observatories. We do it locally and then send it to WHO. And I just wanted to conclude by saying that the motivation for research, we can actually maybe invert this figure by saying if we think about the problems that our community has, and if we work hard to do research to understand what leads to these problems and how they can be solved, we can switch around, we can think locally and then act globally, and maybe perhaps put Pilatus at the top of the world. Thank you.